Good evening, everyone. I welcome you all on behalf of my IAP for Friday Ka Punch, Be the Sherlock Holmes, Crack the Case episode. So, tonight, after the success of previous episodes of Crack the Case, we have a fresh episode with experts like Dr. Pramod Kulkarni sir, Dr. Mahesh Ahirao sir, along with them, we have the moderator for tonight, Dr. Bal Krishna Chaudhary, and the presenter for tonight, Dr. Akansha Beg from AIMS Nagpur. Their detailed introduction I will be giving in some time. First of all, I would like to welcome our President of MahaAP, Dr. Sanjay Pakmode, sir, Secretary, Dr. Amol Pawar, sir, our Joint Convener, Dr. Sanjay Deshmukh, sir, for this program. I would request Dr. Sanjay Pakmode, sir, to begin with his word.
Namaskar. Welcome you to the MahaAP platform, Friday Ka Punch, MahaAP ke Sang. Here, we are given the name Be the Sherlock Holmes and Crack the Case. Now, this particular the Sherlock Holmes, though detective, but he had all the qualities of a very good detective. But why? Because he was having a very keen observation, very powerful reasoning. That's why he was a very famous detective. The same way, for solving any clinical case, we need all these things. That is, taking the good history, physical examination, means with the history, with the examination, systemic examinations, you analyze and you reach to the conclusion. That is the diagnosis of the case. So today we had for this Dr. Pramod Kulkarni sir from Pune and Dr. Mahesh Rao from Dhule. And for this moderator from my own city, Dr. Abhijit Chaudhary, in his absence, Dr. Balkrishna Chaudhary and Dr. Akansha. I just, without the mic to the Herschel and giving all the best to the and again, I welcome all the office bearers, Home Secretary, Dr. Amol Pawar, Dr. Treasurer, Dr. Ravindra Sonone, Convener, Dr. Sanjay Deshmukh, and all the CIPEB and MahaIPEB, and technical person, Mrs. Pallavi, and all the people. Once again, I'm thanking you for joining for the today's MahaIP program. Over to you, Harshal.
Yes, sir. So, a brief introduction about our experts tonight. So, we have our first expert, Dr. Pramod Kulkarni, sir, who is a senior pediatrician and consultant pediatrics and pediatric infectious diseases from Kashibai Navle Medical College, attached to KEM Hospital, Unique Hospital, Dinanath Mangeshkar Hospital, Pune. Our second expert for tonight, Dr. Mahesh Ahirao, sir, professor in HOD Department of Pediatrics, ACPM Medical College, Dhule, and is also director of Chirantan Institute of Critical Care. We have moderator for tonight, Dr. Bal Krishna Chaudhary, who is assistant professor, Department of Pediatrics, AIMS Nagpur, and our presenter for tonight, Dr. Akansha Beg, who is a junior resident in AIMS Nagpur. So with this, I would request our joint convener, Dr. Sanjay Deshmukh, sir, to...
Wait, ourselves. Yeah. So, I welcome our National Treasurer, Dr. Atanu Bhadra, then Dr. Pramod Kulkarni, sir, our senior past executive board member, my mentor, my friend, then Dr. Mahesh Ayyar, sir, from Dhule, another expert, then moderator, Dr. Abhijit Chaudhary, plus Dr. Balkrishna Chaudhary, and also presenter, junior resident from AIMS Nagpur, Dr. Akansha Beg, then Sanjay Pakmode sir, Sanjay Deshmukh sir, then all the attendees, Dr. Ravindra Sonone sir, then Dr. Srinivasan sir, special mention about him. He is joining always to all the Maha IIP as well as IIP programs, webinars from USA. He is very senior academician, retired person, and he has very keen interest in learning from all the juniors, seniors, and everyone. Also, Dr. Sagarwal sir is there from Ahmednagar, then many others, Dr. Dadabhai, Dhule IIP past secretary, then all the attendees, Dr. Mateen Sheikh, dear friend from Sangli, and all the attendees of from all over Maharashtra as well as from all other states of India. So this is very nice initiative of this year about cracking the case with the Sherlock Holmes. Today we have three Sherlock Holmes, Dr. Pramod Kulkarni sir, Dr. Mahesh Airav sir, and this is very useful actually for general pediatricians as well as all the PG students. So and also today, Akansha will be presenting the case which they have treated in AIMS Nagpur. And Dr. Pramod sir and Mahesh sir will be solving this case and guiding all the delegates. So wish you all happy learning. And once again, I welcome Dr. Atanu Badra sir, our national treasurer of this year. Thank you. Over to you, Harshal. Then Sanjay Deshmukh.
Thank you, sir. I request Dr. Sanjay Deshmukh, sir, to say a few words.
So, good evening. In the monsoon magic every month now, this is the day we always look after Hypothetic Punch with the Sherlock Holmes. And this is a great platform for our young presenters who present their cases under the guidance of their experts. And this is the opportunity where we should learn. We can go to our old gold days to learn how to approach the case presentation. So today I am very happy. We have from our own Nagpur city, Dr. Akansha is presenting the case under the guidance of Dr. Chaudhary. And today we have two stalwarts in infectious disease, Dr. Pramod Kulkarni sir and Dr. Mahesh Airav. So it will be great to listen which case is unfolded today. So I welcome all to the My Happy platform, and it will be the happy learning in the monsoon season. Welcome to all.
Thank you, sir. So with your permission, sir, may I request the presenter tonight, Dr. Akansha Beg, to start her presentation?
Yes, sir.
Okay. Can you share your slides? Yes.
So good
You
evening,
can start.
everyone. I'm Dr. Akanksha, Junior Resident, Department of Pediatric, AIMS Nagpur. So welcome to today's Friday Ka Punch, Be Sherlock Holmes Crack the Case. So today we'll see the case of disappearing platelets. Coming to patient detail, 13-year-old female resident of Amravati. She was admitted from emergency. Date of admission 19 January 2025. She was admitted for 24 days. She presented to us with chief complaint of heavy menstrual bleeding since 15 days and generalized body swelling for 15 days. She was apparently all right 15 days back when she developed heavy menstrual bleeding. She uses 7 to 8 pads per day associated with clots. There is no history of foul smelling. It is not associated with pain abdomen. Is history of generalized body swelling for 15 days, which is insidious in onset, gradually progressive. Initially, it appeared around eyes, which then progressed to involve face, then abdomen, then lower limbs. There is no history of reduced urine output, headache, or blurring of vision. There is no history of cola-colored urine, no history of palpitation or breathlessness, no history of jaundice, no history of gum bleed or rash over body, no history of joint swelling. Coming to past history, there is significant past history of nosebleed since 3 years of age, 5 to 6 episodes per year. There is history of 2 similar episodes of menorrhagia in past 2 years, for which she got admitted and received blood transfusion in 2023 and 2024. Family history. She is firstborn out of non-consanguineous marriage. There is no history of any bleeding disorder in family.
લેવાનું હોય કોઈ સેશન કઈ તો એની કઈ તૈયારી કે કઈ મારા ઉપર આવી પડે તો એ કેવી લેવું પડે
Birth
એટલા
history
માટે
was
થોડા
uneventful.
કદાચ
Developmental history, she studies in sixth standard. Average scholastic
Kindly
performance.
mute
Immunization,
others.
she is immunized up till
1
date
minute,
as
wait.
per national immunization schedule.
જોયું મેં કે
પલ્લવી ma'am, પલ્લવી ma'am.
पल्लवी मैम म्यूट करो सबको.
દૂર જો અને પાછા
Personal history. She attained menarche at 11 years of age. Regular menstrual cycle, which comes every month, lasts for 8 to 12 days. She uses 7 to 8 pads per day. It is associated with clot. There is no history of pain abdomen during menstrual cycle. So this is the summary after history. A 13-year-old girl, she presented to us with complaint of heavy menstrual bleeding and generalized body swelling for 15 days. She has a long-standing history of epistaxis since 3 years of age and recurrent menorrhagia with 2 prior blood transfusion history. So I would like to ask my expert what system which they'll think based on history, sir.
So who is to take? May I take it?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
So a 13-year-old girl with mucosal bleeding, heavy menstrual bleeding, that too with early history of bleeding disorder since early life, epistaxis. So these are superficial bleeds. And this child has now been pubertal, has come with previous history of menorrhagia as well. Because her previous menses also seem to be little more than usual. Because 7 to 8 pads per day and bleeding lasting for 8 to 12 days is definitely abnormal. So the child has bleeding disorder without family history, significant family history of bleeding disorder, but I didn't get the history of consanguinity. That is the only thing. So this seems to be a bleeding disorder, that is superficial bleeding disorder, which can be due to commonly due to platelet disorders or vascular disorders or vasculitis. These are the two common things which come to my mind. Looking at the long history, this is more likely to be something congenital or inherited one. That is my initial impression. And about the generalized body swelling for last 15 days, it typically tells me about the pattern of it, starting from periorbital and then progressing downwards over 2 weeks. Tells me something about possible renal involvement. That is the first thing I can think. And 13-year-old girl having periorbital puffiness definitely says it is localized to kidney. So most probably, though we cannot rule out the other thing, though hepatic disorders, I need additional information about possibility of hepatic disorder, or nutrition is less likely at this stage, and what remains is sequestration, that is another thing. So at this point of time, I will think about pre-existing bleeding disorder since early life, mostly congenital, and now 2 weeks history of swelling, which is suggestive of renal involvement. This is the initial impression about this case in my mind.
Hello? Hello? Am I audible?
Yes.
Yes, sir.
Yes, sir. Okay. See, there seems to be two different systems, and at this point, I really don't understand how to connect them. Like there is initial history of epistaxis, as well as 2 episodes of heavy menorrhagia, with now menorrhagia this time even. So it points towards some congenital bleeding disorder. And since it is a superficial bleeding, mostly it points towards platelet problem. Now, this generalized body swelling, as sir said, seems because of renal involvement only. The thing is to connect those two things at this moment is difficult. But something like HUS, where you have decreased platelets, where you have renal involvement, can come. But then why the history of epistaxis and all those things? So at this point, I'll go with sir that it may be. It is involvement of renal as well as the platelet issue. So I think with the further investigation, we will be able to throw more light.
Okay. So coming to general examination, her weight was 32 kg, height was 116 centimeter, which lies below third centile. Severe pallor was present, anasarca present with pitting edema in bilateral feet. JVP was elevated. There was no signs of icterus, no lymphadenopathy, no petechiae, purpura, or ecchymosis. Coming to vitals, she was afebrile on admission. Tachycardia was there. Saturation was 98% under room air. Blood pressure was above 99 centile, 136 by 96. Coming to systemic examination, a CVS examination, S1 was heard, S2 was heard. There was ejection systolic murmur on admission. Per abdomen, it was soft, distended. No organomegaly was there. Respiratory system wise, bilateral air entry was present with no added sound. CNS, no abnormal detected. So after examination, we have 13-year-old. She presented to us with heavy menstrual bleeding and generalized body swelling for 15 days. There is long-standing history of recurrent epistaxis and menorrhagia with 2 blood transfusion history. Examination revealed a severe anemia with tachycardia with elevated JVP, and hypertension and anasarca was also there, sir. So after
So,
examination, what will you think about, sir?
so with these additional points in the physical examination, uh, there are additional clues given by the physical examination. Basically, she is little short for age. Height you have mentioned less than third centile. Number one. Number two, she has got currently anasarca. That says there is subcutaneous as well as body cavity fluid accumulation, and the child has hypertension as well as uh, uh, congestive cardiac failure, as you have said, the JVP is raised. So JVP raised with edema and hypertension. This definitely seems to be a renal disorder and probably a chronic renal disorder. On top of which, along with the bleeding disorder. So these are the two associations. So congenital renal issues, which can be hereditary problems or congenital malformation, along with the bone marrow issues, or rather the platelet disorders or bleeding disorder. This is the additional thing I can think of. The hypertension is little worrisome. Whether it is, it says that the renal issues are relatively acute on chronic, as well as the child has severe anemia as suggested, which could be contributed both by the recurrent superficial bleeds, this time significant one, as well as the renal dysfunction, whether it is CKD as a component of contributing to the anemia part of this child. Because getting blood transfusions for severe bleeding is okay, but this time also it is significant menorrhagia. So these are the things the child is in failure, and the ejection systolic murmur I am little worried about. Ejection systolic murmur is always pathological. All ejection systolic murmurs are pathological. So does this child have that murmur? It is less likely to be due to the hypertension. I will associate it with possible obstructive cardiac lesion or great vessel obstructions as a possibility. That is ES or AS as an additional possibility. So this goes towards a congenital bleeding disorder with acute on chronic renal disorder and a possible obstructive congenital heart disease in form of stenotic lesions. These are the new impressions. I'll be interested in knowing whether this child has dysmorphic features.
No, sir.
Birth weight, what was the birth weight? And was the child IUGR or small for gestational age at birth?
So, birth history was, sir, uneventful. She was full term. Birth weight was, sir, around 2.5 kgs.
So to say it is borderline, so if it was full term 2.5, these days I will call it borderline HGA. So HGA at birth again goes towards towards the possibility of genetic disorder. So this child definitely has some genetic disorder. To combine all these three, we will need additional information as well. That hypertension can be acute as well, acute on chronic or acute alone. The height stunting definitely says it is more likely to be chronic renal disorder. So acute on chronic renal dysfunction, chronic bleeding disorder, as well as possible congenital heart disease in form of obstructive valvular lesion. This is my input.
Uh, Sir, pallor can be explained on the basis of menorrhagia, hypertension, raised JVP, and anasarca is explained because of renal involvement. So basically, I'll still like to stick to the renal and hematological involvement. At this probable time, what I can think is what I thought earlier, like something like HUS, where you have thrombocytopenia as well, which can aggravate the bleeding. It can cause pallor as well, and then hypertension and your anemia and all this can be explained on the basis of the disease. So I like to know the investigations as well. So I think we should move forward.
Okay, sir.
About the HUS possibility, see, the things are since early life of this child.
Yeah,
Okay,
that is only.
and that is HUS
Yeah,
common HUS London variety is acquired one post-infectious immune problem, and the
correct.
congenital HUS is a little different one, severe one presenting early in the life. So
Correct.
HUS I will not keep as a first possibility, but let us put it all together. Some syndromic problem which can explain all three things. Please go ahead.
Yes, yes.
So connecting heavy bleeding with NSARCA, we thought of hematological system involvement, autoimmune involvement, and renal involvement. In hematological, we thought of ITP, von Willebrand disease. In autoimmune, we thought of SLE, considering she is a adolescent
Female.
female girl. In renal, we thought of nephrotic syndrome and HUS. The initial investigation, this was the CBC finding.
None of these conditions will explain your heart failure the child is having currently. Unless there is primary cardiac problem or due to hypertension, the heart failure cannot be explained with the other disorder. And none of these conditions take care of the cardiac failure which you have mentioned.
Sir, can pallor itself cause CCF?
Yes, it can severe, but uh, why Adasartha and slowly progressive over 2 weeks? Acute severe anemia, the bleed will not manifest with CCA. So less likely unless the child
Sir,
had bled too much.
here there are two factors like pallor itself can, and even if there is renal failure, we don't know about the BUN and creat, we'll come to know. But if there is acute renal failure, it itself can explain anasarca, hypertension, and CCF.
Coming to investigation, this was a CBC picture with hemoglobin of 3.6 and platelet count of 5,000. TLC was normal, 7,800 with neutrophilic count of 59%, lymphocyte 29%. The child had severe anemia with thrombocytopenia. This was the peripheral smear finding, normocytic, normochromic. TLC and DLC was same as CBC. Platelet was reduced. It was 30,000 per microliter. Giant platelets were there. This was the absolute retic count report. Retic count was increased 5. This was the KFT report. Urea was 36. Creat was slightly higher, 1.2. This was the LFT picture. Total protein 5.1. Albumin 2.5. With total bilirubin of 0.12, direct 0.05, ALT and ALT 39, AST 27. So this was the initial investigation which we did. After this initial investigation, what clue did this give to you, sir?
So basically, first thing, the child has severe anemia due to blood loss, which is explained by the PBS. It is normocytic normochromic. Being acute, it is not going to be reflected. The bone marrow reaction is not going to be reflected in TBS. That is typical one. The retic count is little high as expected in any bleed. Then about the platelet count, it is 5 on counter and 30 on manual. Then WBCs are normal. Uh, the MCV, MCH being normal. So this goes in favor of anemia of acute bleeding. That typically acute, slowly progressive, persistent bleeding. That typically goes in favor of. And on the size of the platelets, you are mentioned these are large size platelets. That says that there is increased bone marrow production of the platelets, which is working. So bone marrow is working well in this child with only RBC gone down is explained by and higher retic explains the RBC line and bone marrow responsive very well to the anemia. Then platelets, a large size platelet again says the bone marrow is working. So this appears to be a peripheral thrombocytopenia, which is consumption thrombocytopenia. And the creatinine little higher. I will need corrected creatinine and actual EGFR calculated in this child. Liver function seems to be normal. The
Hello.
proteins are down, which can happen in CKD. That can be explained by a chronic renal disorder rather than any other, because hypoproteinemia due to bleeds is very uncommon.
Can you go back?
Yes, sir.
Investigations. Okay. So as per our clinical suspicion, your hemoglobin is low. So the pallor and CCF part can be explained. Now the platelet count is low. It is around 5,000. And on smear, I think they have reported as 39,000 with giant platelets. So with giant platelets, maybe one can think of something like Bernard Solier, where we can get giant platelets. Otherwise, there is some component of acute renal failure as well. Show me the next slide. I think it's 1.2 and 36. Okay. Okay. So still, I would go for consumptive coagulopathy like HUS, and maybe only keeping that giant platelet part in mind and the history, previous history, think of something like Bernard Solier.
Does this child have any cutaneous markers of hemangioma or chronic GI complaints, abdominal pain, PR bleeding, medina of that kind?
No, sir.
No, sir.
Because basically this could be sequestration also, as rightly said. This could be consumption thrombocytopenia. The child doesn't have splenomegaly, which is common cause of, so hypersplenism is the commonest cause of consumptive thrombocytopenia. But if it is not there, as rightly said, hemangioma anywhere, and with that hypoproteinemia, can is there associated malabsorption in the child because of intestinal lymphangiectasia or hemangioma, not lymphangiectasia, hemangioma, which can explain both. But it is expected to be associated with some abdominal symptoms in form of abdominal pain or ER bleeding, something of that kind.
This was the urine routine microscopy report. There was blood trace, protein trace with RBC occasional.
Was there hemoglobinuria?
Sir, blood is a trace with RBC occasional only, sir.
Okay. Okay.
So initial workup, we sent IPF, it was elevated 54.8. This was the coagulation study, which is normal. INR is 0.85. We did UPCR, it was elevated, it was 6,256. 24-hour urinary protein was also elevated, it was 37,242. For our differential, SLE was our one differential, we sent C3 and C4, it was normal. For von Willebrand factor, we did its level was normal within limits, sir. LDH was slightly elevated, not significant. It was 407. We did send ANA profile. ANA IF was negative. We did so bone marrow. We did because chronic ITP was our last diagnosis. It is diagnosis of exclusion, so we did bone marrow. It was suggestive of so megakaryocytosis, no blasts in bone marrow. So after this workup, what will you think, sir?
I will need some additional information here. As you have documented proteinuria as well as UPCR raised on the spot urine, the proteinuria is very much there. With edema proteinuria, whether this child fulfills the definition of nephrotic syndrome, I will need one more thing in that. So edema, hypoproteinuria, proteinemia, and proteinuria. So this is a defined nephrotic syndrome definitely, but less likely to be primary, looking at the age of the child. So this seems to be a secondary nephrotic syndrome. And urine examination somehow is the trace RBCs and blood. I won't rate it very high. So this definitely is a definitely is poor. Here I again think with renal problems and renal with thrombocytopenia. Uh, SLA like situation. But why should it be there since early life? That is little atypical. Maybe SLA usually manifests with other systemic manifestations at this age, which are not there. Skin involvement is not there. So I keep SLA little down. Again, I will go towards some congenital condition and coming with additional nephrotic syndrome. I can't think of any acquired disorder as such in this child.
Hello. Raised urine protein create ratio and the 24-hour urine total proteins suggest that it is a nephrotic syndrome. And now that anasarca and hypertension, all those secondary features can be explained as a part of nephrotic syndrome. Mostly, as Sir said, this doesn't look like a primary nephrotic syndrome. It looks like a secondary nephrotic. So a multisystemic involvement with nephrotic syndrome with a 13-year-old girl, first thing what comes to our mind is lupus nephritis. But since there are no other factors and even the AN and everything was negative, so little bit difficult to comment still. Did you do further investigations?
So our working diagnosis we kept was ITP with nephrotic syndrome. For SLE, what the evidence was for is female with cytopenia with renal involvement, but evidence against was ANA was negative. dsDNA we sent her dsDNA also. It was negative, sir. C3C and C4 was normal. For chronic ITP, there was thrombocytopenia with bleeding history, but that doesn't explain the renal involvement. For we considered von Willebrand disease because there's history of menorrhagia with epistasis, but her levels were normal, sir. We also considered HUS because there was anemia with thrombocytopenia with renal involvement, but there was no cystocytes in peripheral smear and LDH was not that much significant high. Uh, Considering nephrotic syndrome, there was edema with proteinuria, but that doesn't explain the bleeding manifestation, sir.
How
So,
were the
There is an
pulses of this child? How were the pulses of this child?
so pulses were on admission, it was well felt, sir.
The other thing which I can think of is something like PAN, polyarteritis nodosa, which can come like this: renal involvement, hypertension, but the systemic features are not there. And thrombocytopenia is not a standard part of uh, PAN, but it can be there due to the CKD or as a complication due to chronic inflammatory disorder. But the child doesn't have any systemic disorder. And again, the cardiac issue, I can explain it on this hypertension. During the previous episodes, when the child was admitted for blood transfusion, was the blood pressure documented at that time, previous to blood transfusion given? That time, what was the blood pressure of this child?
So there was no any proper documents available. It was only told in history that there is history of blood transfusion.
Were we able to do renal biopsy in this patient?
So we did later, sir, after building
Okay.
a platelet count.
Okay. So that is
Let
to
us first
come.
go ahead with the ultrasound, some additional evaluation of the kidneys and other organs as well. We have done the biochemistry, liver functions we have done. I'll be interested in knowing about the ultrasound report of this child. Chest, 2D echocardiography, and ultrasound abdomen and pelvis, specifically for KUB.
So ultrasound KOB was done. It was suggestive of bilateral grade 1 renal parenchymal disease, sir.
What about the ascites? Was it there? What about liver and spleen?
Sir, liver and spleen was normal size and mild ascites was there, sir.
What about 2D echo or X-ray chest in this child, at least upright erect X-ray to look at the heart?
So we didn't do a 2D echo, sir.
Actually, the anemia part and
What was
failure.
the heart rate? What was the heart rate, and did the child have gallop rhythm? Was she actually in a full-blown failure?
So she presented to us in congestive cardiac failure, sir.
And how did she respond to diuretic therapy over first fluid restriction and diuretic therapy?
So after admission, we transfused her 1 unit PRBC with diuretic. After that she responded well, sir.
So I would have liked to have additional cardiac issues if this child is in CCF. Is it primarily due to renal, or is there any additional cardiac component? So it can be well explained by the severe anemia. We will need some, and the C3, C5 levels are normal. Again, that tells us this is not glomerular. This is not glomerular. So, is it something renal vascular? The problem which can explain both the renal issues as well as consumptive thrombocytopenia. That is a possibility.
Have you gone through the literature? Is there any case reported like this of a chronic ITP and nephrotic syndrome going together? Or
No, sir.
nephrotic syndrome coming in a case of chronic ITP?
No, sir.
Okay.
So
Why
our
should a chronic ITP run for years together? This child had
Hmm.
first bleed when the child was young. Now the child is 13 years old. This is less likely to be chronic ITP. A chronic ITP will exclusively involve only platelets, and this is less likely to be chronic ITP and not towards autoimmune thrombocytopenia or IT. It can be part of autoimmune disease, which can explain all the organ system involvement.
Yes. Yes. Connective tissue can explain. Or sir, can it like what we have been taught is we should not think of two diseases simultaneously, but can it be some congenital platelet disorder like Bernard-Soulier, and the baby patient got a secondary nephrotic syndrome, something like that. So it can explain everything.
So coming to our unit.
To know if the child has received some alternative therapy for that menorrhagia, taken alternative treatment, especially Ayurvedic, some heavy metal containing medications.
No, sir, there was no such history.
In all the things. Okay.
Okay, I think Akanksha, we can move ahead.
Okay, sir. So our unit's working diagnosis was chronic ITP with nephrotic syndrome. Although there was no petechiae purpurae, only history of menstrual bleeding was there. There was few spots, petechiae purpurae at sampling site only. So considering ITP, we started her on short duration of steroid at 2 mkd for 7 days. After 7 days, we assessed her platelet count. It was still low. So we took hematology opinion and they advised for L-thrombo bag. We took nephrology opinion and they advised for renal biopsy. But since our platelet count was on lower side, so after building a platelet only, we planned for renal biopsy. We discharged her on L-thrombo bag and steroid for 6 weeks considering nephrotic syndrome. Patient, she showed little improvement in her platelet count after starting her on L-thrombo bag.
What was her blood pressure at the time of discharge? Her CCF stated. What about the hypertension?
She was discharged on sir 3 antihypertensives. She was having this issue of hypertension.
EGFR, did you calculate it? Which Schwarz formula?
So it was around 45.
45.
So definitely decrease EGFR with anemia, chronic kidney disorder is definitely there. It's not something which is acute. It is long-standing chronic kidney disease with acute nephrotic syndrome.
So after 2 months, she again presented to us, but this time with complaint of hypertension. She was already on steroid, L-thrombobag, and antihypertensive since past 2 months. This was this was her second time admission investigation report. Her hemoglobin was 10 with platelet count of 8. Peripheral smear was suggestive of normocytic normochromic with reduced platelet count 20 to 30,000 with giant platelets. Uh, Despite being on steroid for past 2 months, her UPCR was still elevated. It was 10,373. So after the second admission, based on this investigation, what clue does this investigation give to you, sir?
The proteinuria is persistent and the hemoglobin has not worsened. The child must have not had bleed because of that. But again, the large platelets staying low in spite of your steroids again tells this is not immune mediated thrombocytopenia. This is definitely consumptive thrombocytopenia without consumption of other blood elements. So this must be some sequestration of platelets somewhere. That is the most likely in this child in form of concealed hemangioma. And the renal issue again is not settled because the CKD is the hypertension is very much there, rather worsening. So I again go towards a vasculitic kind of thing or renal artery issues which can explain all this.
Hello. The proteinuria is still persistent, so probably she might need second line drugs, and thrombocytopenia is still, thrombocyte is still there. It is still unexplained. So I think we are not able to do the renal biopsy yet.
Yes, sir, because of low platelet count.
Oh.
Here I will do proactive search for any hemangioma, concealed hemangioma. The best which can be done is renal Doppler. If not, MR angio both the kidneys because uh, before renal biopsy, I will think of other imaging studies which can give us some additional information about the renal structural issue and renal vascular issues. So Doppler at least number one renal artery Doppler, and second I will prefer a MR angio in this child.
Okay, sir.
I think we should move forward.
So second time, this investigation revealed to us that thrombocytopenia is still persistent with hypertension and nephrotic range proteinuria. Previously, we treated her like ITP with nephrotic syndrome with partial response to steroids and L-thrombobag. So this admission triggered deeper investigations because at last admission there was no clear diagnosis. The CBC gave us an important clue. The platelet count was 8 with this peripheral smear. There is a discrepancy between the platelet count in machine and peripheral smear, which gave us a strong clue which we missed on previous admission also with giant platelets. There was persistently discrepancy between this platelet count in the machine compared to the peripheral smear. In peripheral smear, it was on higher side compared to the machine, which is usually seen in macro thrombocytopenia because the machine is not able to read those giant platelets. So secondary causes of nephrotic syndrome with macrothrombocytopenia was worked up, and we started after nephrology consultation. We started her on after hematology consultation. We started her on romiplastim, to which her platelet counts improved, and renal biopsy was planned. genetic study was also sent simultaneously. This was the platelet trend after she was started on romiplostim. Once her platelet count was more than 1 lakh, we did her renal biopsy. This was the genetics report, sir. It was suggestive of MYH9 mutation, which is autosomal dominant condition. It presents with macrothrombocytopenia with granulocyte inclusion with or without nephritis or sensorineural hearing loss.
Oh.
This was the renal biopsy report, sir. It was suggestive of segmental tuftal sclerosis, and here the underlined red one is electron microscopy report. It is suggestive of diffuse effacement of foot process, which is basically which is seen in MYH9 mutation.
Sir, have you heard about this earlier? Pramod Kulkarni, sir.
This is the first time I have heard of this.
Yeah. Even I am hearing something like this for the first time. Okay.
Can I ask something?
Yes, sir.
Does the father or mother has hearing abnormality at the later stage at 50 or 60 years of age, and did they have thrombocytopenia?
So we asked them for parental screening, but because of affordability issue, we're not able to do.
No, you just have to do CBC in that mother and father, because
Sir.
it is autosomal dominance.
Yes, sir.
Somebody must have, because we had a case discussion on MYH9 related macrothrombocytopenia, and that father had a hearing problem, and because of that hearing problem he was posted for some surgery, and then they found that the father also has thrombocytopenia, and then that was a clue that autosomal dominant macrothrombocytopenia is related to MYH.
Actually, sir, in this case, the mother was having some sort of history of hearing difficulties.
Yeah,
but
that is a clue.
But she was not accompanied with patient at that time.
Yeah.
The father was taking care only.
This is a very rare disorder. That's why
Yes,
we
sir.
do not know. But I had a discussion in Mangalore of this recurrent. The presentation was like same, menstrual bleeding, heavy menstrual bleeding, and right from the beginning there was epistaxis. And if you ask somebody from the family that but hearing defect will not be there in this child. They present late at the end of a fourth or fifth decade. That's why you should take a help of parents, that whether they are facing some hearing problem, and that will be a clue that we are dealing. It is very specific. If you put thrombocytopenia, microthrombocytopenia with sensory neural hearing loss, MYH9 is the diagnosis. You can put in chat GPT also.
Yes, sir.
Yeah. It is so, clue is so perfect that if somebody from the parents is not able to hear properly, and they started very late, not in early childhood, okay, at the fifth or sixth decade, or maybe in the fourth decade, but started late actually, and they will also have thrombocytopenia. And because they will not press some, because it is autosomal dominant, penetration is variable. They may not have menorrhagia, they may not have all these finding that child has.
Yes.
So that is a clue. Okay. Thank you.
Thank you, sir.
Balkrishna sir, did
Yes,
you
sir.
think of this, or only after the WAS report we came to know that such and such entity is there in this child?
Sir, previously we searched for that macrothrombocytopenia and nephrotic syndrome involvement. We searched the literature, and we found that there is a Fechner-like syndrome is there. According to that, we investigated this child. And financial constraint was there. Actually, we sent the whole exome sequencing from our side to diagnose it.
Okay. Good.
So initially, to support our diagnosis, we sent first this hearing test, then later we did genetic test, sir.
Okay.
So this was her hearing report, sir.
Did the child have? Okay.
Yeah, she had a mild hearing loss, no? Okay.
Yes, sir. Mild sensorineural hearing loss was there, sir.
But that will not be clinically detected, or they will not come forward with this.
Yes, sir.
They will come
Yes, sir,
forward
yes.
only when they become very severely affected, like mother has now.
Yes, yes.
Okay, that is a typical of MYH9. Mehigan, they call it as.
So our
and
final.
did they have that platelets will be with some gray platelet or something like this. I have heard, but I have
So
not
it's
seen that. What is that? Can you
so
remember this?
basically
They are some
doll-like
Dole body.
inclusion bodies. Yes, sir,
Dolan bodies
doll-like
for that.
inclusion. So that is usually present in, sir, 50% of cases. It can be missed sometimes also. Like in our case, it was not there. We particularly asked pathology, still we didn't got, sir.
Okay, okay, okay. Good, good.
So our final diagnosis was MYH9 mutation with Fechner syndrome likely. So coming to MYH9 related disorder, it is a rare disorder. Mutation in MYH9 gene disrupts non-muscle myosin function, which basically affects platelet, podocytes, cochlear cells, and ocular lens. And it is characterized by macrothrombocytopenia, sensory neural hearing loss, nephropathy, doll-like inclusion bodies, and cataract.
Yeah, cataract also.
Hmm.
So there will be platelet macrocytosis in 100% of case, which will be present from since birth, sir. Thrombocytopenia will be there in 98% of case. There will be bleeding tendency in 80 to 90%, like in our case, she presented to us with complaint of menorrhagia. Sensorineural hearing loss will be there in 80 to 85% of case, with abnormal liver enzymes in 50%, nephropathy in 25%, and cataract in 20%. If these all things will appear in later in life, like cataract, uh, with mean age of onset at around 37 years.
Yeah, in our child, that father had cataract probably, and he was posted for the surgery. And that's how they could know he had also thrombocytopenia. And that was a clue that then he said that his difficulty in hearing is also there. That's why they could diagnose clinically MOH9, and they could
Mhm.
then prove by genetic test.
Oh,
So this is interesting actually. So
yeah.
how once only
Yes.
you know this condition, then you can
Then
search for
only
that.
what the mind, the what you know, only the mind can think.
Yeah.
Yes,
So
Akash.
MYH9 related disorder, it includes May-Heglin anomaly, Epstein and Fechner syndrome. These are basically, they have different syndromic features, sir. It is often misdiagnosed as ITP, SLE, or other bleeding disorder. Like in our case, initially we misdiagnosed her as ITP and we're giving her steroid and L-thrombobal. Genetic testing is the diagnosis gold standard diagnosis. Early identification avoids inappropriate immunosuppression. It is a progressive renal disease, which can further lead to end-stage renal disease, and hearing loss can further lead to deafness. So
Your child at what age he had epistaxis and required blood transfusion?
at 3 years of age, sir.
Yeah, yeah. That also goes against ITP because 3 years and this is 13 years. As Dr.
Mm.
Pramod was always saying that he's not happy with this. It's a long story going by. 3 years to 13 years, 10 years thrombocytopenia probably. And it was a platelet function disorder.
Yes, sir.
And they do not correlate with the platelet count and bleeding manifestation. So started with epistaxis and required blood transfusion.
Yes, sir.
Okay, okay, okay. And at that time there were no platelet size was not mentioned in that previous CBCs.
So previous documents were not available, sir.
Available. That is one more problem in India. We don't have previous documents and we could not get that. And what was the MPV here?
So we did IPF, sir. We don't have MPV.
No, MPV is there in
It
all
is reported in all reports.
all MPV is mean platelet volume.
Yes, sir.
On
Usually
your CBC
in
report.
Bernard Shari, some Mahesh has said, Mahesh,
Ah,
he has said Bernard Shari has mentioned. That was again
yes.
one of the good thing. But
Yes,
Bernard
sir.
Shari is autosomal recessive, and this is autosomal dominant. Mayhagen is autosomal dominant.
Okay.
That's why you could get a clue on Mayhagen in a family.
Mm-hmm.
Autosomal cataract and
Correct.
hearing loss. These will be there, but Bernard Shari will not be there. Bernard Shari
Yes.
will not, because the size of this platelet are very large. They can have more than 13 is almost diagnostic of micro thrombocytopenia.
Hmm.
Okay, they do usually young platelet do not cross that 13 value femtoliter. 13. Anything above 13 or 15, you can think of this genetic disorder then.
Okay.
Coming
Good
to
case, sir.
conclusion, we should consider MYH9 syndromes in any child who presents with persistent macrothrombocytopenia with nephrotic range proteinuria and incomplete response to steroids. There will be discrepancy in platelet number in machine compared to peripheral smear because of this macrothrombocytopenia. Whole exome sequencing, it helps us in confirming the diagnosis, and multidisciplinary management is required. In our case, we discharged her on romiplostim for maintaining her platelet count, and with antihypertensives, she was started on AC inhibitors, which will help her in proteinuria.
Protein.
A nice case indeed.
Yeah.
Yes, Dr. Balkrishna, sir, any final words over this case?
It was an unusual presentation, as in the first time we kept it as a ITP, but in second admission we thought of we are missing something. So we went in deeper, and that's how this case diagnosed.
All the dots were not joining properly.
Yes, sir.
Initially. So I thought of two separate. Could it be two separate disorders in? But as our seniors have taught, as far as possible, think only of one disease in one patient at a time. Okay. Good, sir.
Very nice case discussion and well cracked by our Sherlock Holmes. And
no.
If another message is there, if there are more than 2 or 3 organs involved, we have to think of a genetic condition, do genetic study.
Yeah. Yes, sir.
Yes.
Even everyone was thinking in terms of connective tissue disorders.
Yes.
All the feedback was going in favor of connective tissue disorders, but somehow it was not fitting.
Right.
We
Yes,
thought of ANCA actually. I thought of ANCA, small vessel vasculitis
vaginous.
with ANCA. But what was not fitting is started from 3 years of age.
Bleeding. Yeah, and bleeding.
Bleeding started from 3 years of age. Then we have to think of something different, because ANCA and without treatment will not last for 10 years.
Correct.
Or any vasculitis or connective tissue. And they will not start at such an early age. But if they start, they are usually monogenic then. In SLE, ANCA, all these things. All these are monogenic disorder which can start less than 5 years.
Yes.
Excellent case, but
yes.
Thank you.
Yes.
Very good case. Thank you very much.
So with this, I would like to thank our presenter, Dr. Akanksha, for presenting this superb case. Also, big thanks to the experts tonight, Dr. Pramod Kulkarni sir and Dr. Mahesh Ahirao sir. And also, thank you, Dr. Balakrishnan sir, for being the moderator for tonight.
Thank you, sir.
Thank you.
Thank you very much. Thank you.
Thank you very much. Good night.
Good night.
Good night.
हॅलो मॅम
मॅडम बंद करा.
मॅडम बंद करा. थँक्यू महेश सर एव्हरीवन.
night,
थँक्यू. गुड नाईट सर. गुड नाईट अश्विनी अग्रवाल सर. गुड नाईट आकांक्षा यशवंतराव सर. एव्हरीवन. शंतनू डॉक्टर शंतनू सरवार. गुड नाईट एव्हरीवन. पल्लवी मॅम, you can end the meeting. Are you there, Pallavi ma'am?
अमोल सर, आवाज येतोय माझा?
Yeah, you can end the meeting. Meeting is over, ma'am. Thank you.